Hi, and welcome to Mind Your Health. I am here today with Dr. David Burke, and we have wonderful guests.
No, I actually lead peer support sessions for groups of people that work through all different ICUs. And so I hear stories from those that are in adult ICUs and the neuro ICUs. And, it's amazing how much I think even some of those older adults can impact you too, because I hear stories from these younger generations of people that are saying, hey, yeah, I just took care of somebody that really reminded me of my aunt.
Mind your health.
You got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
Dr. Whitney Marvin is joining us, and she is a pediatric critical care doc. How did I do?
Yeah, great.
That's great. In Charleston, it's so great to talk to you. We talk to a broad spectrum audience, but I think you offer a lot of insight, and we're excited to sort of dig deeply into your brain today and find out a little bit about the world of a pediatrician, and especially in critical care. So, Dr. Whitney, can you share with us a little bit about what you actually do?
Yeah, so wear a kind of couple different hats, but one of them, my clinical hat in the pediatric ICU, is that I take care of either babies, kids, teenagers that are critically ill or injured. So what that means is once a baby goes home from the hospital, anytime
Okay.
they have to come back, and if they're really sick, they come to our ICU. And then we take care of all the way through kind of young adulthood. Sometimes kids are continue to follow by some of the pediatric subspecialists. And so I'll even take care of some young adults at times.
So, do
And
you?
then,
Go
yeah,
ahead. I'm sorry.
sorry. I was going to share, I do have a second hat that I wear, that I help kind of supervise a team actually of well-being leads. So people that are interested in kind of improving the well-being of our healthcare workforce
Mm.
as well.
And that's really interesting. We were actually talking about that today, about trauma-informed care, and how health workers have a really high incidence of substance use and abuse dependence, and then also suicide.
Yeah, and unfortunately, those statistics are real and they're pretty scary. So we're trying to do everything we can from, both local, nationally, to spread awareness about that and really make sure that we're taking care of ourselves and taking care of each other every day, both in and outside of work.
What specifically do you do or do you focus on in that arena, if you will? This is sort of taking a shift a little bit, but I
Yeah.
think it's really important.
Um, so I think, like me personally, or advocating for, or
Yeah,
both.
advocating for both is good.
Yeah, I mean, I think that, there's really good evidence coming from, Stanford's model of saying that, shifting from the old mindset of a lot of well-being and wellness was just personal based. And yes, that's part of it, right? Personal factors, but
Right.
we try to focus on both how we work from an efficiency point, and then also just organizational change. So where are we, and how do we interact with our workforce, both from a leadership level, but even a systems level too.
Hmm.
So I think trying to work on all of those. And I think, as a leader, as an advocate for this work, I think one of the most important things is just modeling it, right?
Okay,
So,
correct.
I try and be open and transparent about, that like it's okay to take care of myself. And this is how I do that. And this is what it looks like for me, but it also may look different for other people. And trying to be open about acknowledging what that looks like. And then, being able to partner with people and say, hey,
Hmm.
we've got an opportunity to improve our efficiency of practice here. Like, is there a way that we can work together to make, to try and get rid of some of the pebbles in our shoes, to make
Hmm.
us work at the top of our license and, find a little bit more joy in the work that we do every day?
Do you find it difficult with healthcare workers, especially those working with children? I mean, I get, seeing an adult patient there and trying to do your best, and, sometimes bad things happen. But I think it's such a naturally human emotion that when you get a little child there
Right.
and a child is deathly sick, or a physical trauma, do you find that it's so much harder for healthcare workers to heal and, I don't want to say
Cope
disconnect.
with,
Yeah,
yeah,
that's a good word.
yeah.
Coping with what they're seeing right in front of them.
Yeah, since I'm just in peds, it's hard for me to compare one way to the other. I'd say that, what I'd say is that I think everybody is exposed to different trials and tribulations in different ways that are in healthcare right now, right? So, it's not, it's less common that I have, somebody that's like trying to physically hurt me, right? Because most of them are like much smaller kids. Is a child's death hard? Does it feel natural? Absolutely.
Right.
Right. Absolutely. Does it impact those that take care of them? Absolutely. But, I actually lead peer support sessions for groups of people that work through all different ICUs. And so I
Mhm.
hear stories from those that are in adult ICUs and the neuro ICUs. And, it's amazing how much I think even some of those older adults can impact you too,
Mm.
because I hear stories from these younger generations of people that are saying, hey, yeah, I just took care of somebody that really reminded me of my aunt or my mom or my
Oh, yeah.
grandmother, and how impactful that can be. Yes, it is an older adult, and maybe the idea of dying since they've lived a longer life, I think to a lot of people would say, well, that's not as bad as a kid, but I think it doesn't take away the fact that it's
Yeah,
impactful to them,
Yeah.
exactly.
and to the people that are around that.
And how do you deal with just peers? Someone who, let's say, an ICU, pediatric ICU doc, that's a pretty stressful position, I would think. And how do you all deal with each other? Is that part of this informed care that you're really doing?
100%. I think that community is such an important piece of well-being when you talk about it,
Hmm.
right? So people that feel connected is really important. And part of what I value so much with my job and the different teams that I'm on are the people that I get to work with. And so a lot of it is that when we know each other and we can lean on the support
Yes.
systems that are around us, right? So, hey, I may not agree with what's going on in
Right.
this room, but we have a wonderful ethics team here. And so they're great about like sitting down with us and walking through some of those like feelings of moral injury about like, I
Mm.
don't think I should be doing this, but can you help me,
Right.
deal with those feelings? And so I think as a team, the community that we have built is just absolutely key to trying to, keep that joy in the work that we get to do every
Well, you
day.
know what's interesting about that as a psychologist, you're a pharmacist. I mean, I think if I, in an old system, came and said, look, I'm really struggling with some major anxiety and I have become dependent on a substance, I could potentially lose my license if I disclosed that. And so I think now part of the trauma-informed care model is creating systems, right? Tell us a little bit about that and how that would work, because it's really a safety thing too.
Yeah, I mean, I think that you guys are probably familiar with like the Lorna Breen and Heroes Foundation.
Yeah.
So that's where a lot of well, I mean, I wish that this had started a lot before that, but she was a emergency medicine physician that died by suicide, and I think was very scared to get help. And so her family has really made it their life's mission in her name to support that. And I think, we always say that the basis of everything is first, you got to get it out of any sort of legal documents,
Right.
right? Any sort of we can't have it when we're saying, signing any of our licensing or for the state, for the city, for any of that, that we got to take that out of it. So I think that's step one. And then step two is really at a unit organization, city, national base is being able to acknowledge like it's okay to not be okay.
Mhm.
And it's okay to take care of yourself and be able to support that. We have the institute something called stress first aid at our institution. And wonderful human who's managing that. And the idea of stress first aid is built off of psychological first aid. I'm not sure how familiar you guys are with it, but
I'm
we're really
not.
trying to focus. We're trying to focus on training teams. The idea of it is actually very easy to understand.
Okay.
So it's stoplight based. So green is good. Like I'm in the green. We want to grow the green is something we talk about. We are kind of working at our best, clear minded, doing great. Yellow is kind of like you're feeling a little bit more of that stress, kind of a little bit of that more like kind of sympathetic and activation, still functioning well. That's a lot of
Mhm.
Mhm.
people kind of how they function at work, right? In a stressful environment. It's not common that I'm like sitting in the ICU in the green. I'm not,
Right. I'm not
it's
there. That's right.
not that environment. That's okay. And then the orange is where you're starting to feel more of that like wear and tear. And we talk about stress injuries. So,
Yes.
death, moral injury, there's a few others. And then red is when like, hey, I have like had these symptoms and they've been going on for a month. I'm really not in a good place.
Mhm.
And so we're intentionally trying to train teams and individuals at our organization to learn how to use this language, because what it does is it gives you another framework instead of
Yeah.
saying, some people get scared to say I'm not okay,
Right.
but it seems a lot easier to say I'm in the orange right now, like I can't, I'm in a fog, I don't even know how to help myself, like I'm so overwhelmed, but that's where I am.
Oh, I absolutely love that. And I guess the real question I think David and you and I both have is how do you think that positively impacts the quality of care you deliver, um, really from a patient point of view? And how does that impact overall healthcare
Mm.
in general?
I mean, I think we're from a healthcare in general standpoint, we're trying to shift culture,
Yeah.
right? So I think this is where we are, and I think we are in a major shift of saying that, let's take care of ourselves, acknowledge that some of this is hard, and over time, you know, be able to shift culture. And I think that's where that is. From a patient care standpoint, we use this, you can use this wording even just from an overwhelming busy day, right?
Right.
You could just have a million things going on and just be like, oh my gosh, I have, especially from like nurses at the bedside, RTs at the bedside, when they're like, I've got one or two very sick patients right now. Like I am overwhelmed. I'm in the orange.
Yep.
I,
I'm
I have
orangeing it.
work done
Yeah.
that I can do. And there may be someone in next to him that like, hey, slept great, exercise.
Yeah.
Their assignment isn't as heavy. And they're like, hey, I'm in the green. How can I help?
It's really
So
funny because as a psychologist, we use this I use stoplight all the time with littler kids to tell kind of what how they're feeling. They can't put words to it. There's no language. They're
yeah,
too little. But if they know if they're red, green, or,
Yellow and
yellow.
orange.
Yeah,
Mm.
they really actually do. You know, when you and I first talked at the conference, it was really interesting because you were talking about how the nature of being a pediatrician has shifted, and a lot of that is due to social media and the internet, AI, things like that. Can you share with us a little bit about how that makes your role a little bit extra challenging?
yeah, I think, one thing we had talked about earlier was that, um, I most of the people that went into medicine, in the last handful, couple of decades, a lot of us went into idolizing these people that were physicians, men and women that were physicians that really grew up in an era without internet. And so they were very much
That's
idolized
us.
That's
as,
us.
you know,
Oh, hell yeah.
leaders in their community, right? And
Right.
and that what their foundations were is what most people did.
Mhm.
So it just that and AI has just completely changed our construct of
Mhm.
how patients look at this relationship, and even now how physicians, interact with patient care too.
Sure.
Everybody is leaning on AI to kind of help them make the decision and everything. But I think that it's just taken that extra to understand where so or why they're asking those questions.
Right.
So, and I think there's always that I always try and say that, like, if I can understand the why, it's going to help me take care of you better or your
Mhm.
child better. Because are you scared that something's going to happen? Or is it that Chat GPT told you that this is actually what the diagnosis
That's right.
is?
Right.
So,
Well,
yeah, I
Al,
think yeah, a different phase that we're entering.
I also I think we've come light years to hear you talk about, this team and that team and this team, where typically years ago there wasn't teams.
Correct.
It was, this is my doctor. I have one doctor. He's going to make all the decisions. I trust him. And I think to everyone's betterment, we've
Uh-huh.
moved to teams. We're a team approach of doctors, nurses, pharmacists, physical therapy, all the different modalities all together coming to
Mhm.
a mutual decision.
Yeah, it's absolutely interesting. Um, and I think that many of us, it's funny because my son's a doctor too, and he's always talking about people come in and they have chat GBT'd it. They have gone down the Dr. Google rabbit hole. I can only imagine if it were a child or, you know, with that extra fear too.
Well,
Yeah.
what I see in my practice too is children are not just small adults. they're different. They react differently. It's not, oh, if the dose on an adult is 2 tablets, well, my
Right.
my kid's a little bit smaller than I am. I'm going to give him 1 tablet or half a tablet. I'm like, no, the math doesn't work out that way. They're not the same.
So what is the percentage of time you deal with parents versus the actual patient in your practices?
I mean, I don't even know. I think of us all as, a team.
Yeah.
So obviously I'm taking care of the patients. And so I'm with them all the time, hands on. That's what I'm managing. But, I always will tell families, and I think families that have spent a lot of time with me will tell you, like, I will be very clear to them, like, my job is also to take care of you, make sure you guys feel as supported and as knowledgeable about what's going on with your child,
Hmm.
as possible. And so I would say that, they're an extension of part of what I think I'm responsible for. So because, this is their experience too. And I want to make sure that they are getting everything that they need to feel comfortable and safe in their child's care as well.
Let me ask you a question, more broad spectrum about kids. Can you, or how do you feel about the ability of separating um, the kid's physical being from their emotional well-being or mental well-being? Are you seeing a lot of that interplay?
And 100% I will say I'm general pediatricians and family medicine docs and everybody that I think is out in the community that are seeing kids well are seeing it even more,
Okay.
right? Um, so 100%, I think they would be better to speak to it. But again, I think it's all part of it. And it's part of, what we, even from not even just an emotional standpoint, but like a psychological standpoint,
Right.
right? So we've become much more in tune about like what is delirium and how do
Mm.
medicines that we give, like how can they impact kids? And so we're very, every day, we're being very full about, what our choices are, risk benefit and, trying to improve kids, mental state and well-being, even in the ICU. But I'm sure that general pediatricians are seeing it uh, to a much higher degree.
So I want to go back, if I can, just to your specialty, because I think clearly it is a specialty a lot of us aren't really acquainted with. You gave us sort of a broad overview. You're a pediatric ICU or critical care doc. And so typically then are you um is that a specialty that is relationship driven, or as much as it is kind of skill? You have to be you have critical patients, so you've got to be kind of on it, and then they move down to a more to a transition, if you will.
Yeah, to lower acuity. I mean, a
More
hundred
acute,
percent.
that's the
I
word.
think we to do ICU in any level well. I think you have to be able to do kind of a wide breadth of skills.
Mm.
Okay.
So one, procedurally, two, just clinically, and then three, ideally, it's really important to be able to build those strong relationships, right?
Okay.
So, because, as we talked about earlier, unfortunately, not all kids are going to survive, and there are kids that are going to die, and there are things that, that no matter how hard we try, that we just can't stop.
Mhm.
And so, what part of our job is trying to support families through those times. And I think, that relationship piece is really important.
We were talking about, are you a
Oh, yes.
yeah, a relation-driven physician? And you were sharing that it's, yes, you are relationship driven, because whether you lose a child or a child is injured or in an accident, it really takes a village to kind of heal everyone. And that goes back, Whitney, to the model of trauma informed care I think you're talking about, which are
Mhm.
basically, what she's saying is, yeah, we're going to take care of ourselves. And I'm going to model that behavior and extend it. Is this what I'm hearing? I'm going to
Mhm.
extend that to
Absolutely.
the folks when they have a critically ill child or young adult. So it's basically not, we're sorry, move on, next patient. It's a lot
Mm.
more. Who are some of the members of the team when you have a critically ill patient that you think are important?
Yeah. I mean, truly, we have a very massive multidisciplinary team. So, I mean, every day on rounds, it's us and trainees and a dietitian and a pharmacist. Um, the bedside nurse, if it's they're needing help with breathing, we have a respiratory therapist that will
Wow.
join us. Sometimes a charge nurse will join us. Sometimes, depending on kind of where patients are. So it's a massive team, and it really is a joint effort. And I think in families are part of this, right?
Mm.
So we're really focused on family centered care and family centered rounds, and so
Mhm.
families are always invited to join. Now, some families choose not to, and that's also okay. They say, like, I don't want to hear all the numbers and the data. I just want short updates, and that's all I want to hear, and that's okay too.
Do most
But they
parents
need to be a part of it.
do most parents stay with their kids throughout? And again, when rounding or things like that, are parents invited to go along with the kids for most
They
things?
Parents are always invited. Rounds happen at bedside.
Okay.
So at bedside or right out the door if patients are on precautions and that the
Right.
whole team can't enter. But parents are always invited to join rounds. Some parents choose not to. And there's a lot of parents that don't have the ability to be in the hospital when their kids are. That they are having to work because they don't have leave. They don't have the money to be able to not do that even if their kid's really sick. So we try and do our best to obviously communicate with them, whether it's on rounds or meet their whatever their needs are to get
Hmm.
updates, how they want to see them if they
Mm.
can't be there in person.
Just random because we can. Where did you do your training?
So I did med school in Nevada, and then I did residency and fellowship in San Diego
Oh,
at
did you
UCC.
really? Okay. And then moved to Charleston, which is so lovely. I love that for you. Well, you've been amazing to talk about. I know that we can do deep dives in a lot of different things that you're interested in. Do you have a prescription or a daily habit that you think for Mind Your Health is something that you would like to share with our audience or our viewers?
Yeah, I'll share. I think I have two things that I've become very intentional in it's kind of, I call it in my self-care practice. One, exercise, which a lot of people, that's their jam, right?
Yep.
But so
Oh
I'll
yeah,
talk
Oh
we're all
yeah.
about it.
Yes.
and the other thing that has become really helpful for me and my family, because I'm married and I have kids at home, is a routine when I leave work. And so that transition from leaving work, from especially those like really high acuity, sick, stressful days, is that, I get to go home and shower and I get 15 minutes to myself. And so I give myself that time to, think through, give space to any of those like moments, feelings throughout the day. And then, that is kind of my like physical change of like, I change my clothes and I'm out, and then I try and shift to those other roles.
That's
So
actually brilliant.
that
I
is
love
one of the
that.
most successful things that I learned later on in my career.
Well,
Yeah,
Dr. Whitney Marvin, thank you so much for
yeah.
sharing your expertise and your knowledge and just your insight into your profession. And we thank you very much from Mind Your Health.
Thank you guys for having me.
My pleasure.
Mind your health. You got to mind your health.